morning about what needs to happen as overall vision. We have spoken about specifics of scientific advantages and how AI/ML is driving it. And now it's time to actually bring it home and focus a little bit to India and see what's really the need of the hour that we have to address, so that we are not kind of missing parts which are most relevant to the country. And while the organizing team just gets the session title before here, kind of let me set the context. Here we are going to focus on the neglected and tropical diseases. As some of the speakers in the morning also alluded to, that, the big pharma, typical, I think Dr. Khorakewala said this, that big pharma goes after therapy areas such as oncology, and the infectious diseases get neglected. And then if there's something that's even further neglected, that's, I would say, the tropical diseases and some of the neglected diseases, which are very characteristic for developing economies particularly. And here we'll see how to build a roadmap for that. And we have a session that is curated by two distinguished professionals here, and I would want to go ahead and introduce them. So first, I would like to introduce Dr. Chirag Trivedi, who is Global Clinical Early Operational Strategy Lead at Sanofi. Dr. Chirag is a PhD in pharmacology with extensive experience in clinical research, clinical quality assurance, medical excellence, pharmacovigilance, bioavailability and bioequivalence studies, and business development. So really a very, very rounded experience in clinical development is what Chirag brings to the table. And he's working in Sanofi since 2006, previously as director and head of clinical study unit for India and Southeast Asia, overseeing clinical studies across multiple countries, including Singapore, Malaysia, Thailand, Indonesia, Philippines, etc. He has notably also served as the president of Indian Society for Clinical Research from April 2017 to March 2021, where he significantly contributed to the policy shaping for clinical research in the country. And his prior experience includes roles in a CRO and a central laboratory, providing a very broad operational and scientific perspective in clinical research management. And I would now like to move on and introduce Dr. Manisha Ginde. She is partly the reason why we all are here, because she is representing the Vasu Foundation. She is a physician and pathologist by training, and she co-founded Diagnosearch in 1995 with Dr. Vasudev Ginde. 1995 was a time where central lab was not even a term that was understood by many in India. So it's very, very commendable what she and Dr. Vasudev achieved together in terms of developing this central laboratory and then, furthering into various aspects of clinical research development. So she is today overseeing the scientific operations and quality systems for Diagnosearch, apart from leading the central lab and medical services functions. Dr. Manisha is a certified internal auditor from the College of American Pathologist Inspector, and she has contributed extensively to SOP development and assay standardization for leading government and university laboratories worldwide. So without further ado, I'm now going to hand over to Dr. Chirag to take the proceedings of session 3 forward. Thank you.
Thank you so much, Sunila. If you want to learn the art of settling scores, probably look at the steering committee here. I'm sure you understood this is a post-lunch session, right? Now I'm just increasing the alertness quotient so that... Thank you, Sunila, for the nice introduction. It's a topic which was when we discussed in the steering committee to see that what is it that we can do specific for India. Manthan is a very good initiative. So how can we bring in specificities to India, which probably is not answered in many ways? And that's why we've got the experts now to talk about some of these neglected tropical diseases as well. Amongst that, first one I'm going to talk about is Dr. Kavita Singh. Of course, she needs no introduction. She's been a healthcare and biotechnology leader with more than 20 years of experience here. She herself is, of course, a medical doctor and began her career at Shanta Biotechnics, so one of the earlier biotech companies here in India. and then served as the mission director for National Biopharma Mission under the Department of Biotechnology, and the Asia Continental lead at DNDI, the Department of Neglected Diseases Initiative of India, and the leading large public-private partnership to advance innovation, manufacturing, and also regulatory excellences in life sciences. Of course, currently she is serving as the independent director on the boards of Gennova Biopharmaceuticals and Social Alpha here. With her, she brings in tremendous expertise in governance, R&D oversight, and sustainable business models that connect scientific innovation with the societal impact onto the patient. So without further ado, I'm going to ask Dr. Kavita Singh. She's going to talk about the canvas of neglected tropical diseases with focus on research in India.
Good afternoon, everyone. While I was listening to the CART session, the previous one, and you understand the nuances and the deep science and tech in this era, my one of the thought was, is it a paradox that the next session is neglected diseases, which we have been fighting for centuries, or maybe even some of them are mentioned in very old books of Sanskrits. But whatsoever, it's a conversation which I am personally very passionate about. Yes, my previous role at DNDI gave me much more deeper insights. And in fact, what I've done is I've picked up some of the pictures, which are pictures of patients to date. They are not older click pictures, just to bring home the fact that many a times when we attend pharmacology conference or drug development conference, we miss the central pillar around for whom the drugs are being developed, and that's the patient. So just bear with some of the pictures of patients, especially for lymphatic filariasis, and Shiva, I also have for mycetoma. So. Also, I was asked to give a brief context because we've been using these terms, the tropical disease, the tropical infectious diseases, the neglected tropical diseases. Where are we, just so that we all are on the same page when we use these terms. Most of us, yes, did read it during our undergrad days. But so when we use the term tropical disease, so it's both, communicable and non-communicable diseases. But of course, we know the geography, the latitudes between which the people of that part of the world reside, which is very clear in that map. When we say tropical infectious diseases, we are certainly remembering you're talking about more tropical diseases, but which are infectious in nature. And Dr. Valecha would talk more about malaria over there. And then there is a subgroup of neglected tropical diseases, which is a very classic bookish definition of WHO. And WHO has identified about 21 diseases. They had 20. Last year, they added one more, 21. And these are the diseases which are complex as such. If as you'll see this life cycle of the worm of LF, and you'll realize it's complex. You see about VL, you'll see it's complex. Most of them, not all, many of them are vector-borne, but the very common picture, which I'll come out in the next, very obviously in the next conversation is, so I'm struggling with this. Why are NTDs classified separately? Why did they need a separate mention by the WHO? Is these diseases, many of them carry a lot of stigma. They're chronic diseases. They are diseases which are, of course, in the tropical belt, but they are also diseases which see least investment on R&D. And that's the reason we see, despite our elimination efforts for decades and decades, we have not seen investment happening, either from the government, the tune to we want. I will not say not see, but to the tune which this whole package of 21 diseases needs. The other thing which is also very obvious for these diseases is that while in tropical diseases we see higher mortality, we have TB, HIV, malaria, but NTDs usually are long-term, they are chronic, they have more morbidity than mortality, except when you don't talk about rabies or snake bites, which are of course a different one. But in addition to the tropical factors of nutrition or genetics or vectors or humidity or climate, these patients of NTDs also have some very socio-economic determinants for their disease, which we mention as poverty, sanitation. So they not only need drug R&D. They not only need diagnostics, they don't only need prevention, but they need a lot of other support from the government and their own societies. Mentioning about India, many of you have mentioned that yes, it is important that we are closer to home because 40% of the 1 billion population which suffers from NTDs or which have the potential to suffer, they live in India. So that's this burden we still see today. And in fact, 14 out of the 21, 14 are still prevalent in our country. I've just also named, we know that they belong to different microbial classes. There's a fungi, there are bacterial, there are viral, there are parasitic. And many times the biggest shock, people express is when you say even dengue is an NTD. Especially Dr. Kulkarni sitting here may not agree because he's working on a map for NTDs, but it is still, because it is still a disease which needs much more R&D, much more conversations. But you see a whole spectrum of that. I've just picked up a few examples to bring home the point. What sort of gaps are we talking about? And I start with one of the diseases called PKDL. I don't know how many of you remember PKDL. Anybody here? Any takers for PKDL? First, Kala-azar dermal leishmaniasis. Like I said, many of them are the precursor of this disease. VL is also, of course, a neglected disease, but PKDL is more of a morbidity condition. You see some pictures, it's a maculopapular to nodular rash, and these are all Indian patients. This disease comes in about 10 to 15% of patients who recover from VL. And after a few, say about a year or 18 months or 24 months, even to date, there is no point of care to diagnose this disease in the peripheral health centers or in the states of Bihar, Odisha, Eastern UP, where we see this, Jharkhand, where we see such patients. There is, for a VL, there is a point of care, but for PKTL today, again, we have to take a skin biopsy. We have to stain it and see an LD bodies under the microscope. Imagine doing all that in a primary health center. And even if you diagnose it, the treatment today is a 12-week oral therapy, which was actually developed for topical cutaneous cancers. This drug causes teratogenicity. I mean, it is a teratogenic drug. And this drug also causes ocular toxicity, with some patients even losing their eyesight. Now, is it justified to give? Yes, it is critical to give because we are targeting elimination since 1990s. We've been having a control program. We are closer now to our elimination only as a public health problem, not the next steps, very early elimination, what we call as. And so do we need to do discovery now for the drug? Miltefosine is a drug which is given now, which is teratogenic acid, which can cause ocular toxicity. But if we don't treat these patients are carriers of the parasite in the skin. So if you get the numbers of VL down, the vector sandfly, which is always there, will get the numbers back because there's some very few patients who would develop PKDL and silently, asymptomatically carry the parasite in the skin. So that's the burden even today since we're struggling for this disease. The second which I talk about, and I said lymphatic filariasis, just to be quick, I'm not talking about the life cycle, but you see a life cycle between a mosquito and the human, and this large worm resides in the large worm resides in the lymphatics, and the small microfilaria is what circulates in the bloodstream. And the present drugs are all drugs which are microfilaricidal, and the intent is to stop transmission. You kill the microfilaria which are in the blood, but the large worm, which resides in the lymphatics for 4 to 5 years, continues to release those microfilaria. Even today, for doing the assessments, I don't know how many of you remember, but the healthcare workers or the frontline workers have to visit the homes of these patients between 10 p.m. to 12 a.m. because that's the time when microfilaria comes out in the night, to keep its cycle very intact, its life cycle. That's the time when mosquitoes bite. So do we still need to have a better diagnostic, a simpler diagnostic, which doesn't need these sort of night visits, patients are awake, the frontline health workers are awake. Also, I'm sure Dr. Tarunla will talk about it. With ICMR, we just started a trial because till date, we didn't have a drug which could kill the large worms. So should that be a priority? Just to also let all of you know, in 1955 is when the first control program of LF was started. And I jumped the slides. It is still in the year 2023, 20 states with 345 districts are still endemic with LF. 1955, the first control program started. The third disease, which I'm sure, again, Shiva will cover much better for fungal, is this mycetoma disease. It's of two types, bacterial and fungal. Of course, it is the fungal which I have described here, because the bacterial has treatment, though a very long treatment. Again, a disease which doesn't have point of care, a disease which doesn't have a treatment which can be given, say for 2 months, 3 months. The present treatment can have 12 to 18 months. So imagine a resource-constrained subject living in an environment where he needs to have an expensive treatment for 12 to 18 months, needs to undergo a surgery, needs to have food for absorption of that drug 4 times or 3-4 times a day. And till date, we have never had any clinical trial. This disease was first described in India. Therefore, it also has a name of Madura foot. And till date, we have never done a single clinical trial in India. We go by clinical experience. Okay, let's see how long a patient takes to recover. And my last one, is of course dengue. Dengue is very well known in terms of the clinical practice. But even to date, if you ask the clinicians, they're not the best satisfied with the point of care diagnostics in terms of both sensitivity and specificity. We don't know, we don't have a biomarker till date which says which patient will progress. So it's a disease which predominantly is asymptomatic, but which patient will actually progress from a mild disease to a severe disease? Do we have a biomarker? We don't. Do we have, when there are outbreaks and suddenly our hospitals get constrained with patients, can we have some mass drug so that the patients don't progress, which is affordable, which is safe, which is a small molecule, can be given to families, can be given to care, healthcare, the household contacts, so that they don't develop from mild to severe and our hospitals don't get overburdened. And just to conclude, so there are lots of areas where work can be done. It could be, we also talked about registry of cancers. Can we expand our R&D strategy? Can we have more public-funded drug discovery? Can we do diagnostics, surveillance? And of course, Dr. Taruna, requesting for a standing national NTD committee, which would really add value. And with that, I think I should conclude. Thank you so much.